right, thanks, Eric. Good morning, everybody. And today we're talking about dealing with shoulder instability. I think everyone has heard about the arthroscopic Bankart, and it's become, at one point, was trying to push it to be the gold standard of instability surgery. And as things continue, just like in Dr. Swan's talk, things can kind of go round and round. So this is a perfect example of a big wheel that just continues to spin. We don't really know where it's going to stop. So we all deal with shoulder instability with our high school and college athletes, obviously a very common injury. And they present in many different ways. The patients present either with a dislocation, and a dislocation has to be reduced on the field or on the sidelines. Or the athlete may tell you that their shoulder popped all the way out and then it went back into place. Or was it just a subluxation? Sometimes it's hard to tell the difference. And they might not even know the feeling that the shoulder is subluxed. They might just feel they had a dead arm or something, their arm got numb or tingly or something like that. So then you have to worry about, was it their first time that they ever dislocated their shoulder or had an instability event, or has it been recurrent, and how much trauma was involved in the injury? Then we start to think about return to play issues. So then was this an in-season injury, or did it occur out of the season? And if that's the case, like how much time do they have left? If it's out of season, does the season start next month? Does this happen in camp? Or do they have 4 or 5 months to recover before they have to be back? If in season again, is it the beginning of the season where your goal may be to get them back in season to playing before the season is over, or is it towards the end of the season where no matter what you do, the season's going to be over before they recover from the injury? So, there's so many things that go into the decision-making process on how we're going to manage these athletes. And of course, there's always, is it a contact athlete? So is it somebody who dislocates their shoulder serving a tennis ball, or is it someone who dislocates their shoulder getting slammed into the boards playing hockey? Or as I tell all my wrestlers, despite what you tell me, I know you're trying to dislocate each other's shoulders on the mat. So, and then in the years of participation left, are they a freshman? Are they a sophomore? Are they a senior and they're going to get a job out in Wall Street, never play sports again? These are, again, all the factors that come into how we manage these patients. When the patients get the injury, they're almost always going to get an x-ray. And what are we looking for in x-rays? Oftentimes athletic trainers will reduce the dislocation on the field, or if it was a subluxation, it's obviously reduced. So when they go to the emergency room, it's relatively uncommon to see a dislocated shoulder, but sometimes either there's no one trained around to put the shoulder back in, or it just doesn't go back in that easily. So they go to the emergency room and get an x-ray. And what you're really looking for is any type of fracture that may have an impact on your management of the patient. So the typical things we look for is a small crack near the greater tuberosity, although in our younger population that's relatively uncommon. More important to look for is a fracture of the glenoid rim, and we'll talk about that in more detail as time goes on. Then the next question is, do you do an MRI or an MRI arthrogram? In the acute phase of an injury, the shoulder has hemarthrosis in it, so there's probably blood in the shoulder. You may not need to inject dye into the shoulder. If some time has passed where the fluid in the shoulder has resolved, an MRI arthrogram may be more helpful. But again, if you're even ordering this study alone is not cut and dry. Let's say you're in the middle of the season and someone dislocates their shoulder and they want to get back on the field. Is the MRI really going to change what you want to do? Probably not. So those are just things to consider. And then the big question is, when they come to the office, doc, I dislocated my shoulder, should I have surgery or not? And that's, there is no one size fits all with shoulder instability. We treat a lot of patients very successfully, non-operatively. We treat a lot of patients operatively, very successfully. But there's so many factors that go into that decision that there is no one size fits all. But over the years, people started to look at the arthroscopic Bankart repair, which can be a relatively straightforward operation. It's, as opposed to doing open surgery and all the issues that go along with open surgery, basically through 3 portals can repair a Bankart lesion, and the patients can recover pretty quickly, although it doesn't really speed up the return to play or recovery from compared to the older fashioned open surgery. And I've been around for a long time. I learned on open surgery. I didn't actually even learn how to do an arthroscopic Bankart as a resident or a fellow. It evolved to the point where arthroscopic Bankart became more popular and started to say, well, this is equivalent or maybe even better than open surgery. And you will see today that we're going to see how that wheel is continuing to spin as we go forward. So I think the first question is, what is an arthroscopic Bankart? So first thing is, what's a Bankart lesion, or what is a Bankart type injury? So when someone dislocates their shoulder, essentially what happens is they peel the labrum and the capsule off of the glenoid. That's not on the screen, is it? Is there a way to get the mouse on the screen over there?
Put the arrow on the.
Where is it? Oh, there. Yeah, I'm not moving it. I think Brandon's moving it. So. I just want to go over some of the anatomy of the injury. Sorry about that.
So it has to be. You're trying to play this video?
No, it's not a video. I just want to point.
Oh, you should be able to point. It's gonna be kind of complicated.
All right, never mind. All right, so in the upper left picture, you see the anatomy of the injury, and that's the Bankart lesion. So essentially what happens is the labrum and the capsule pull away from the glenoid rim when the shoulder dislocates. And you would think, that for whatever reason has very low healing potential. Probably the most common reason is there's full of joint fluid, and the synovial fluid inhibits the healing of the labrum and the capsule back to the glenoid rim. So your goal in what the quote-unquote arthroscopic Bankart repair does is you basically sew that labrum and capsule back to the rim of the glenoid. So in the middle picture on the top, you start to see the preparation of the glenoid rim. You remove some scar tissue and fibrinous exudate and things that prevent healing. Then in the upper right, you start to drill holes into the rim in preparation for suture anchors. On the bottom left, you start to pass sutures through the labrum and the capsule, and then tie it all down, and when you're all done, have an arthroscopic Bankart repair. So it seems pretty straightforward, right? You just, go in, prepare the bed, put your anchors down, sew it down, and you restored the labrum back to an anatomic position. And then pictures on the right, they're just arthroscopic photos. So the top picture is a probe showing where the labrum is separated from the glenoid. And in the bottom picture, you see the final product of an arthroscopic repair with the sutures bringing the labrum back up and over the glenoid face. So you've restored what's called the bumper effect of the glenoid labrum. So arthroscopic Bankart has been around for quite a while, back even into the late 1990s. And when it first started off, it was an operation they didn't have some of the tools that we have today. So the repair was done with transglenoid sutures. So you do it arthroscopically, but we would drill a hole all the way through the glenoid, pass sutures through the labrum, and tie it onto the back of the shoulder. And again, I'm getting pretty old, so I remember the initial presentations of this study saying that they had really good results, and they were results at 1 and 2 years, saying we have results that are equivalent to open surgery. Then fast forward 3 to 5 years later, I'm going to the same meetings and the same authors on the podium, and they say, well, you know what, things worked pretty good at 2 years, but at 5 years, things are not really looking very well. So we have to rethink what we're doing with the arthroscopic Bankart. But perseverance exists in our nature, and so we figured out we're going to do this better. And technology helps a lot. So that at the time of the transglenoid sutures, there were no suture anchors. So that's why you had to drill all the way through the glenoid. So they came out with this really great device, a suture anchor, where you just put a little plug of metal into the rim, and it has sutures coming out, and then you can use that to pass your sutures through, so you don't have to drill all the way through. And that was okay, but the problem, if we go back just real quick to the Bankart lesion, if you hit the bottom, like in the bottom row, you see that the Bankart lesion extends to the very bottom of the glenoid, and sometimes it even goes all the way around, and that can be difficult to access arthroscopically. But now with curved drill guides like flexible drills and flexible suture passers, we really have a lot better access to the glenoid labrum, and even our knowledge of portal anatomy can be better and help us do a better job of sewing that labrum back down to the glenoid and managing the capsule, which I think we'll talk about is a big part of this whole concept. So with bigger, better, and faster equipment, we decided we're going to persist, and we are going to continue to do arthroscopic Bankarts for shoulder instability. And there's some really good evidence-based literature that lends itself to itself. We all kind of know that in our young athletic population, the recurrence rate of instability in athletes is, you could quote anywhere from 60 to 85%. So Sandy Kirkley, who was in Ontario, is kind of really one of the leaders in randomized, really well done randomized prospective studies. This is like a landmark study where she looked at a group of patients who had first-time instability and treated with arthroscopic Bankart versus non-operative management. And you can see this was a 6-year follow-up. The second paper, the first paper was done at 3 years. And they only, in the surgery group, they had an 18% recurrence rate, whereas in the non-operative group, they had a over 60% recurrence rate. So this, and a few other papers at the time, really started to lay the path for we should be fixing these shoulder dislocations with an arthroscopic Bankart, because we've reduced the recurrence rate markedly with an operation that's really what we could consider minimally invasive. At the same time, when you looked at the outcomes of open Bankart repair done at the same time of this publication, the outcomes were even a little bit better. The recurrence rates were lower, but it was a bigger operation, harder to recover, and even back then, the right operation for an open procedure hadn't really been decided upon. So this arthroscopic technique really started to take hold. Another really great study, this was done in the military by Craig Battani. So now you're looking at military recruits who are they obviously have to continue on with their training. So they did a randomized prospective study, again, arthroscopic versus non-surgical management in active duty males. And again, you see that the recurrence rate is very high in the non-operatively managed patients and only very low in the not in the operatively managed patients. All this was relatively short-term follow-up. So this and a plethora of other papers really led us to the point where we started saying this arthroscopic Bankart is really a great operation. Forget the open surgery, and I do a lot of open shoulder surgery, and especially when somebody weighs 300 pounds and you have to get down to the shoulder, it's a little bit of a hog wrestle. If you do it through arthroscopic portals, actually you don't really feel like you've got a workout at the end of the case, so it's kind of nice. But as a lot of orthopedic surgeons like to say, what's the worst thing for your results is follow-up, right? And this is a perfect example. So here's as the wheel continues to spin. So now we see the long-term results after arthroscopic stabilization with suture anchor, so an arthroscopic Bankart. And now this was a really well-done study out of the Netherlands, 97% follow-up. This was at around average 8 years. And now their redislocation rate is up to about 35%, and 13% of those patients had additional surgery. And you're going to see through this talk, you're going to see this little graph on the bottom right called the Kaplan-Meier, which basically shows how your failure rate over time. And I'm going to just tell you, if you always look at this graph and look at 2 years, at around 2 years, you're going to see a drop-off. So these arthroscopic Bankarts, where you're just sewing the labrum back to where it belongs, that's what an arthroscopic Bankart is. They do pretty well early on, but give them a little time and they start to fail. And again, I could show 10 more papers with the same kind of graph that looks the same way. So this is just a perfect example. So what's the problem? Like, why isn't this operation working? Because we're putting the labrum back. We have an injury, the labrum falls off, we put it back right where it belongs, but it doesn't seem to work a long time. So the problem is it's not just the labral pathology that causes the instability. It's really multifactorial. You have the glenohumeral joint capsule. So obviously, there's in the shoulder, it's not like a knee where you see a big ACL. We know that this primary stabilizer for instability is the anterior band of the inferior glenohumeral ligament, but you can barely see that ligament if you want to know the truth. It's really a thickening of the capsule. There's not some big rope going through the shoulder that holds it in place. So when you dislocate the shoulder, yes, you peel the labrum away from the glenoid, but you also peel the capsule away from the glenoid. And Lou Bigliani at Columbia showed us a very long time ago that with a shoulder dislocation, you get the labral tear and you get actual plastic deformation of the capsule. And it occurs both anteriorly and posteriorly. It's not just the anterior capsule that gets stretched out, but even the posterior capsule stretches out. So you do have to think about the capsule as part of the cause of instability. And then people have all different types of capsules, right? There's people who are really tight jointed. There's people who have hyperlaxity, mild cases of Ehlers-Danlos. So a lot of it goes into the capsule, and the capsular stability may be just as important, if not more important, than the labrum itself. The labrum is really just the anchor point of the ligaments and capsule to the glenoid face. Everybody talks about the bumper effect of the labrum, and it is important, but the capsule may be even more important. So that's just one aspect of why maybe these aren't working so well. The other thing is the bone anatomy. So always hear about Hill-Sachs lesions. So what is a Hill-Sachs lesion? Well, when the shoulder dislocates, the humeral head comes out anteriorly, and the back of the humeral head kind of rides on the anterior rim of the glenoid, and you'll get a little indentation fracture on the back of the humeral head. Now, in the upper picture, that's a relatively shallow and mild Hill-Sachs lesion, and on the bottom picture, you see a more pronounced Hill-Sachs lesion, and we've seen Hill-Sachs lesions even deeper than that. So we started to look at these Hill-Sachs lesions, again, which are kind of, again, going back a long time ago, relatively ignored, I would say. And then they started saying, well, does the Hill-Sachs lesion engage with the glenoid rim? So in other words, in that shallow one, the likelihood of that indentation fracture in just routine daily activities, or maybe, in sports, re-engaging on the rim, on the anterior rim of the glenoid, where the shoulder could pop out, may not be so significant, whereas the bottom, with a deeper lesion, it may be easier for that to engage in the position of abduction and external rotation. So it's been studied even further to the point where we have on-track and off-track lesions. So if it's an on-track lesion, then the Hill-Sachs lesion doesn't engage with the rim of the glenoid. And if it's an off-track lesion, then it's very easy for that deep hole to pop over the rim of the glenoid. So we started to pay more attention to the Hill-Sachs lesion in our x-rays and our MRI evaluations. And finally, the thing that we've heard about the most over, I would say, the last 7 to 10 years is glenoid bone loss. So there's just a CAT scan of someone who had a shoulder dislocation. And you can see that when they dislocated their shoulder, instead of causing, maybe they did have a Hill-Sachs lesion because the head is removed, but they actually broke off the rim of the glenoid. So the labrum is attached to that piece of bone in the bottom right corner of the glenoid, but it's off the glenoid itself. And now you've lost some of the surface area of the glenoid. And I had to fight really hard to not put a golf tee with a golf ball on the floor next to it, because we've seen that picture about 1,000 times. But this CAT scan really shows what happens. Now, if you get into that acutely, you can put that piece of bone back and the patient might do very well. But if you leave that piece of bone alone and say, we're going to get through the season, or the patient doesn't want surgery, that bone starts to resorb or get soft or lose its shape. And now that bone's gone forever. And now you've lost some bony stability on the glenoid side of the joint. Now, if you look at the two, you have the Hill-Sachs and the glenoid, we do see bipolar lesions. So you have Hill-Sachs with glenoid bone loss. Now you really have a problem. So again, we can't really say one size fits all. This is one of the reasons why patients aren't doing particularly well with arthroscopic Bankarts, because of these 3 points that we'll talk about in a little bit and how they're managed. Now, since we started seeing more of these failures of arthroscopic Bankarts, our colleagues in France, and I would tell you, French orthopedic surgeons are the most advanced arthroscopic surgeons in the world. They push the limits of what we can do arthroscopically. And they came up with this Instability Severity Index Score, which was kind of led by Pasquale Below, who's one of the leaders in shoulder surgery, especially instability surgery. And if you look at the score for this system, they said, well, let's look at these factors and determine what predicts people that won't do well with instability of the shoulder. So age, they use the age of 20. Is it a competitive athlete or recreational athlete? Is it a contact athlete or forced overhead, or just not in that category? Then you looked at categories like hyperlaxity, Hill-Sachs, and glenoid. So you just take the top 3, age less than 20, competitive athlete, and a contact sport. I mean, number one, we already have 5 points right there, and that's almost everybody we take care of. Then you take any of the factors below that, shoulder hyperlaxity, Hill-Sachs, or a glenoid, or a combination of, and then you're going to be over 6. And what they found is that if patients had an ISS of 6 or greater, then their recurrence rate was 70%. So they recommended a Latarjet, which we'll talk about in a little bit, but that's adding bone to the anterior inferior glenoid. So this kind of took hold a lot and started saying, well, maybe this is the first chink in the armor for arthroscopic Bankart repair. Maybe we need to think about how often should we be doing this operation. Here's an even more interesting study from another one of the French study groups in shoulder instability. So this is 97% follow-up on patients who were treated with isolated arthroscopic Bankart repair. And these patients, none of the patients had a score greater than 4. So they were 4 or less. And in this group, they had a 35% redislocation rate. And 13% of those patients had to have additional surgery. And again, if you look at the Kaplan-Meier score of the patients that had an ISIS score of greater than 2, that's the green line. I can't point to it. You see that after 2 years, that really drops off. If they're less than 2, the blue line, they stay relatively acceptable rate. So it's only a score of 2. So if you go back to this score, that's everybody. I mean, it's a high school athlete. You're 2. Why are we doing an arthroscopic Bankart? I think this is a really solidly done study, again, because they're not including patients who had an ISIS of like 6 to begin with. It's 4 or less, and they have a 35% failure rate. So what are we thinking about, right? So now, like, what could we do better? Like, we're kind of making the case for maybe the arthroscopic Bankart isn't the ideal operation. Well, again, and harping on my old age and experience, I've learned on the open Bankart repair, and I would tell you that I've always done this on contact athletes my entire career and been very happy with the results. But why is this a good operation? Well, it's good because, number one, we put the labrum back to where it belongs. You see that on the left side. And that's relatively straightforward, but it can be challenging in bigger athletes. Excuse me. But the other advantage of the open operation is at the end, when you're done repairing the labrum, now you can manage the capsule. And as you go into the shoulder, you can look at the capsule. It looks a little loose. It looks a lot loose, whatever the case may be. And when you close it up, you can close it up in a way we call a capsular shift. You can take the inferior capsule and bring it up high. You can bring the inferior capsule, bring it up high, and the high capsule and bring it down low. Essentially what you're doing is you're taking that balloon that is the capsule, and when you close it, you're decreasing the volume of that capsule. So now you've done a Bankart repair, you've repaired the labrum, but you've also addressed capsular laxity, and we've seen better outcomes. So again, if we compare arthroscopic Bankart, just isolated arthroscopic Bankart, to an open Bankart repair, we're seeing good lower recurrence rates in patients who are done with open, although the patient-reported outcomes, the PROMs, weren't really that much different. So again, I'm just showing one paper as an example of many papers that have shown, especially in high-risk patients, like maybe contact athletes, patients with hyperlaxity, that you'll see a lower recurrence rate that lasts longer in an open Bankart than an arthroscopic Bankart. If we move to the Hill-Sachs lesion, this again goes back to Craig Batani and J.T. Tokish's work out of the military, looking at the glenoid track concept. Remember I said, so if a patient is on track, that means their Hill-Sachs lesion doesn't engage on the glenoid. If it's off track, it engages. So these were 57 shoulders who had arthroscopic Bankart, but they went back retrospectively and looked at the MRIs. And if there was an on-track lesion, the failure rate was less than 10%. Off-track lesion, so a big Hill-Sachs, 75% failure rate. So again, what we're finding out is that the Hill-Sachs lesion is something that, again, we need to pay much more attention to than we paid a long time ago. So what's the solution to that? Well, here's the latest. I'll tell you, this is really, John Kelly down in Philadelphia has been an advocate of the remplissage for a really long time, and his outcomes are very good. So what is remplissage? Well, it's a French word that means to fill. I don't know any French other than remplissage. So it means to fill. So when you do your arthroscopic Bankart, you repair your arthroscopic Bankart, but you have a big Hill-Sachs lesion in the back. What can you do? Well, I mean, sometimes people talk about putting like an osteochondral allograft back there or something, but that's probably not going to be good. You don't know if it's going to absorb. And this is a relatively straightforward and simple arthroscopic procedure where you essentially tenodese the distal portion of the infraspinatus tendon into the Hill-Sachs lesion. So you're filling that defect with capsule and the infraspinatus tendon, and that basically tightens up the shoulder enough. You're again managing the capsule, managing some rotation with an arthroscopic procedure. The downside to this, in some reports, there's a loss of external rotation that may or may not be significant. But if you look at this comparison of arthroscopic Bankart to arthroscopic Bankart plus remplissage, the patient-reported outcomes are essentially identical, but the recurrent instability rate goes from 18% down to, 18% down to almost 4%. So we've really seen some very good numbers in terms of the remplissage, and I think this is becoming a bigger part of the arthroscopic surgeon's armamentarium. If you get in there and you say, wow, that Hill-Sachs is bigger than it looked on MRI or something, this is a relatively quick solution to that problem. Then the thing that's gotten the most attention recently has been glenoid bone loss, and this is called, and we address this with Latarjet. So again, looking at a comparison of arthroscopic Bankart to an open Latarjet. The green line is the Latarjet. It barely drops off after a really long time, but look at the blue line, 2 years, it drops off, right? So again, we have an arthroscopic Bankart, gives us excellent short-term results. Again, taking care of young people, it's kind of easy, right? They're young people, you fix their shoulder and then they move on, right? They go to college, they move out of town. So you don't really know if they dislocate again. It's really like, I'm a great surgeon, but if you really, again, what's the worst thing for your results? Follow-up. And this is a perfect example. Our French surgeons have really promoted the Bankart or the Latarjet repair. And so what we do with that case is we take a portion of the coracoid process, which is right there, saw that off, and then sew it onto the anterior inferior glenoid, and that basically widens the bottom part of the glenoid and prevents shoulder instability. And in France, this is so common that this is their operation of choice for shoulder instability. Like, they don't do open Bankarts, they don't do arthroscopic Bankarts, they do Latarjet procedures, but Belot's gotten so good at it that now he does it arthroscopically. And there's all new ways now. We're talking about using distal tibial allografts, so you don't take the conjoined tendon off. And then JT Tokish is talking about using the distal clavicle as an option. And these free bone blocks can be implanted much more easily arthroscopically than trying to actually saw the coracoid off arthroscopically and transplant it onto the glenoid. But again, this is just an example of where an open procedure kind of blows an arthroscopic Bankart out of the water. And then Matt Reventure is really like one of the American leaders in shoulder surgery when it comes to instability. He was in the military, out of the military, in the military, and everybody turns to him for his opinion because he's followed this journey through a very long career. And he recently had an editorial on a very well done review article on arthroscopic Bankart, and this was the title of his editorial. Is it time to take a stand when arthroscopic Bankart is no longer a viable option for anterior shoulder instability? So in his patient population, which again is young, active military people, plus all the thousands of people who get referred to him, if the patient presents with multiple recurrences, whether they're dislocations, instability, they just have multiple feelings of instability. If they've had more than 2 dislocations, if their symptoms have been greater than 6 months, so if you had an instability that you kind of blew off because you want to get through the season, it's been more than 6 months, the Hill-Sachs lesions, the glenoid bone loss, they're not ideal candidates for arthroscopic Bankart, and he's probably going to talk them out of that operation. So then we have to go back, well, who is the ideal candidate for an arthroscopic Bankart? And, we don't want to try to fit a square peg into a round hole. So in my mind, if I had to say who's the ideal candidate for an arthroscopic Bankart, was somebody who had a first-time dislocation without having prior instability episodes. Someone said, like, my shoulder never felt loose, I never felt numb, never had a dead arm, I just like ran into the outfield wall and my shoulder popped out of place. They have time to recover. In other words, you say, well, if you want to play next year, if your season's coming up in a month, surgery's not going to have you on the field, but treating you non-operatively is going to have it. So they have to have time to recover, and you're probably looking at minimum 3 months, preferably 4. They should be a non-contact athlete. They shouldn't have hyperlaxity, and you're going to have to examine them for like a Baton score. Do they have hyperextension of their elbow? Check their other shoulder. And you have to carefully assess their x-rays and or MRI to see if glenoid or humeral bone lesions. They have none of those, then an arthroscopic Bankart is probably a very good option for them. And it begs the question is, if you go back to some of the things we talked about, the bone loss can occur over time, capsular laxity can increase over time, Hill-Sachs lesions can get bigger over time. So if you do have a young athlete who has a first-time dislocation without any prior history, is it more cost-effective to fix them early with an operation that works to prevent them starting to wear out their shoulder just enough that the arthroscopic Bankart is no longer an operation? That's probably a topic for a whole nother talk, but it is a very, very interesting question. So thanks for your time. Appreciate it.